Hello, and thanks so much for joining us for this 15-minute lightning session. These are the answers that you need in the time that you want. We all know that everybody's Zoom and Teams overloaded, so we wanted to make these as quickly as we possibly can. Quick bites of information, those little nuggets that you can remember about your virtual healthcare strategy. Today, we're going to talk about telehealth reimbursement with Christie Musser and Cynthia Scheideman-Miller. And we wanted to also define that this presentation was done on January 18th, 2021. So the content of this presentation is informational and shouldn't be construed as legal advice. It's important to check with any of your payers or state laws for formal guidance. And then, of course, things are changing all the time. So as of the date of this presentation, as I said, the information is valid, but note that things change on a regular basis. So Cynthia, give us the scoop. What do I need to know about the geographic and originating site restrictions?
We get that question a lot, and most of the restrictions fall within two categories. One is rural versus urban, and then the other is what type of facility that the patient is at the time of service. For example, prior to COVID and the PHE waivers, most telehealth visits occurring in the home were basically retail or for a handful of specialty visits. Medicare tends to be the most restrictive, mostly due to legislation. And the good news is that we're seeing trends outside of Medicare, that the Medicaid and state telehealth acts are generally less restrictive for the geography and patient location. And the trend is to reduce this even more. We saw a lot of legislative activity this last year, making permanent what the PHE waivers had put in place temporarily. And one of the things is that we keep seeing a lot of is the home as a eligible site for telehealth services. So again, for those of you, I'm assuming everybody that's listening knows what the origination site is now that I'm saying that. And that is the site where the patient is. And that's considered where the service is actually being delivered, is where the patient is.
And we know that the PHE has been extended just recently, just in the last day or two, for another 30 days, and they've already committed to that 60-day glide path. Anything to add to that, Christie?
Nope, it's just keep your eye on that.
Keep a close eye on that one. Also, audio-only visit reimbursements here to stay, question mark? What do we think our options are if it goes away? What do you think, Christie?
So audio only has been a fun topic during this pandemic and the waivers. So one of the options would be to discontinue audio only as an option for a billable service and go back to the way it was, which probably most of us aren't going to do that, but that is an option on the table for your practice. But absolutely would create a policy that allows for audio only and describe when audio only can occur. So the appropriate times, certain conditions, patient does not have technology or access, and build your templates and your documentation around that so that it's clearly seen, because of what we're seeing is payers are stating that audio only can be for the situations when patient does not have technology or access or does not wish to use video. And then when we talk about audio only, you want to still think about clinically appropriate services as defined. And I'm going back to that policy, make sure you have a policy. You could provide a discount on your retail fee if not a covered service or uninsured. Or you could even go on to adopt a virtual check-in protocol, which that term is used with CMS, but it's taken off in the world outside of Medicare, and use that as a triage protocol clinical scenario, which you now bill for. It's a phone call, and there's appropriate codes designated by CMS. Some of the payers are also covering those. And they've actually added on another code, which we'll talk about a little bit later. But it's really around audio only. It's still a little mucky, but best bet is to create a policy and everyone in your practice be on the same page and making sure that you are communicating and messaging that out to your patients.
Yeah, good point. You do mention in here on their third bullet point there that should not offer a discount if it's a covered service, but applied to a deductible or there's a copay. That's sometimes where people get a little bit squirrely. They're not sure what we should do with that. So I wanted to point that out as well.
Yes, and we'll cover that again actually in the reimbursement as well.
Okay, great. Anything to add to that, Cynthia?
Nope.
Perfect. And then we have patients that'll be moving, vacationing. This happens all the time. Lots of hospitals and health systems talk about this. We have somebody that's going to another state when it's really cold or it's really warm and they want to go to a more climate appropriate space or that they like. So what will happen when we go to another state? We want to know, is that going to be covered? What do they need to know in these particular cases?
Yeah, and that again gets back to the service is considered to be delivered where the patient is at. And it's really hard for providers sometimes to think about that because if they're seeing a patient on a computer screen, they look the same to them. And, it may be a little different room, but otherwise it's the same. So when people ask that, my question, I have a couple. One, we've already established it's an existing patient, because that's usually what they're asking about is existing patients that are vacationing. And I said, is this ongoing care or a new diagnosis? Because if it's ongoing care, then that's treated a little bit differently in some states than it is otherwise. So the ongoing care for like diabetes, most states say that it is, 1 or 2 visits, and they really don't care about that then because it's just continuity of care. And every state has licensure laws, so you have to really pay attention. Now, some states like Arizona have where a lot of people go to, as you said, stay a longer time period, have said for, again, ongoing care for an existing condition, that it's up to 10 visits. So because they realize people stay a little longer. So you really have to look where that patient is going. Now, if it's a new diagnosis, while the patient's in another state, almost across the board, there may be 1 or 2 exceptions, but usually they say you have to be licensed in that state if it's a new diagnosis.
And so there's something called the snowbird laws, right? When they're incorporated. Go ahead. Sorry, I didn't interrupt you, but I wanted to make sure we clarified that.
Yeah. And it's very specific by state. Most of them, it's 1 or 2 visits and for a ongoing condition. The other thing to consider that a lot of people don't think about is malpractice. Does your malpractice insurance cover you if you're seeing a patient in another state? Sometimes they, again, if it's continuity of care and it's a one-off, then that doesn't matter. In other cases, sometimes though, they say you have to be licensed in the state or we're not going to cover you. So you have to really check with your insurance, your malpractice carrier, to see if they will indeed follow you if you see patients in another state and what their rules are. And then the third caution is reimbursement. You may have malpractice coverage. You may have your licensure laws may say, yeah, go ahead and do it. But will you get paid for it? Reimbursement, the different payers may say that patient has to be in the state for us to cover you, particularly like in Medicaid. We see that a lot of times. You have to be in the state or possibly in a border county. Sometimes they're very precise where the patient can be to be covered by telehealth. And so, again, those 3 things are probably the 3 biggest things you have to think about. It isn't usually just simple enough that, yeah, they love me as a provider and they're moving to a totally another state and that's okay, I can keep following them. No, you have to be licensed at that point.
Yep, definitely a place where we think a lot of advocacy needs to be done for legislators to understand that this is a big problem for healthcare providers, whether trying to provide continuity of care and just simply a vacation or a small trip to another state or such is affecting that continuity of care for sure.
And remember the licensure compacts, you might want to look into those.
Yes, thank you. Very good point. And some states are participating in medical and nursing licensure compacts, depending on the state. So what are the options if reimbursement discontinues or changes after the PAT?
Great question. And I think that, again, we're still in kind of this wait and see. It's not going to discontinue across the board. We already know that because some things have been made permanent. So one of the options would be continue to accept insurance for virtual care services with the discount policy for those who are uninsured or underinsured, put that policy in writing and review annually. There are going to be payers that continue to accept it, whether Medicare continues with their geographic and originating site restrictions going away. Another choice is if for some reason everybody quit, or you said, listen, I don't want to deal with the insurance pieces here, you could say, we're going to offer this virtual care service and we're going to set a uniform price for it, and that's what we're going to charge. Then you actually could bill that out to insurances. If they pay for it, great. If they don't, you bill the patient. There's no discount involved because you are setting the same price across the board. You could enroll in and accept third-party payers and then opt out of Medicare and only do the third-party contracts. That's a very unusual scenario nowadays. Most providers do accept Medicare. Move into the cash only realm and do subscription programs. You see a lot of that popping up, but again, realize that you then are not dealing with the insurance. You're limiting yourself to a certain population that would like to pay cash only. Also, something to consider is direct to employer model programs. A lot of employers are starting to piece off their insurance coverage for their employees into segments and pay for certain things that will keep their employees either healthy and or cared for in a less costly location, but still providing quality care. So consider reaching out to your local employers and find out what they need and what they're looking for and what you could provide for them. Did want to mention that CMS, even though the pandemic may end, they are currently allowing the Category 3 codes that are temporary to be payable through the end of calendar year 2023. So they're giving us some time, and also themselves some time to review some of those codes that maybe we could advocate for and make permanent. Private payers have those very policies and the geographic restrictions originating sites. But as mentioned earlier, the trend is to eliminate those restrictions, but we have yet to be seen with Medicare.
Definitely a place for advocacy. Lots of legislators are asking about this. There's bipartisan support to remove this geographic site restriction. So get out there and talk to your legislators and call your lobbyists and your individual health systems. Anything to add to this, Cynthia?
No, the only other thing I'm thinking about is in case of managed care, I think that we're going to see some continuation there, or, like total knee replacement, or there's certain handful of things I think that this will continue to be used very frequently. So that's another option as our reimbursement tends to change a little bit on the style of reimbursement, that's something to think about.
Yeah, so some of the bundled payments, that seems like a perfect place for that to just continue.
Exactly. Yeah, post-operative visits would be another one that comes to mind. So utilize it in those areas that reimbursement's not necessarily an issue.
Right. So what about the specific restrictions you're seeing? Go ahead, go for it, Christie.
Okay, so some restrictions. One thing that I don't think is really widespread known is that many of the laws in our states are actually putting in clauses around women's health and the ability to prescribe the abortion pill through a telehealth visit. So that's just something to be aware of, and in your state and what your state looks at. I believe there's a handful of states that do have that in, and it has become a talking or a point of
or even birth control pills.
Right.
They're putting those in as specific restrictions, which is unfortunate.
So that's just something to look at in your state laws, in your state telehealth laws. That's where we're seeing that come down. Behavioral health. So it has been decided they are going to sunset the geographic and originating site restrictions post PHE. So that is a huge win. But just be careful. They're still saying that there needs to be an initial visit in person in the first 6 months. And then after that, at least once every 12 months. Unless, there's always an unless, I love it, the physician or practitioner and the patient agrees that the risks and burdens associated with an in-person visit outweigh the benefits that are associated with furnishing the in-person item or service. They don't define it beyond that. So you providers will have to understand what that means and make sure you document it. So it looks like there is a loophole with that. And I do believe that this is still being assessed.
Yes.
So just keep your eye on that. But I think that is something that it's exciting, unique to behavioral health. And we know behavioral health is huge. So that's a win for any of you who are in behavioral health.
Absolutely. Make sure you document that in the medical record, as Christie notes there. So what should be included in the teleconsent form?
Well, there is no one set answer. Again, every state has different rules. Many state statutes and rules, Medicaid programs require a telehealth informed consent prior to service. Luckily, a lot of times the telehealth language can easily be incorporated into your existing patient consent form. So it may just be as simple as adding the definition of telehealth. I understand I may do telehealth. I understand technology happens and a call may be disrupted because of technology issues, something along that line. Many accept verbal consent, which has to be documented. As Christie just said, you document everything. If you don't document it, it didn't happen. And if you're seeing patients in multiple states, which is one of the questions we get a lot of, we say, go to your state that has the most restrictive consent form, and then just have one consent form for everybody, but then you're covered. You've got it taken care of. One of them that was recently that we looked at was the Virginia Board of Medicine. Their guidance document is one of the more thorough consent forms that I've seen. And so that's kind of just as a general rule. Some of them you even have to state where the provider is at the time of service and what the provider credentials are. So very carefully look at what the state statutes are for every state that you serve patients in, because it can be quite different from state to state.
Absolutely. Lots of nuances there, but we certainly have provided lots of folks advice in that area as well, and make sure they're covered from a policy and procedure perspective. But what other non-traditional telehealth benefits, like the communication technology-based services?
So this is something that, again, I don't think is known to the extent that these are services that were actually available to us as providers and clinicians prior to the pandemic. So although we have lumped them into telehealth under under CMS, they are not lumped into the telehealth. Therefore, they're not subject to the same restrictions, but they do have restrictions, just not the same one. They don't have originating site geographic restrictions. But just quickly to go through virtual check-ins, we talked briefly about that. That's going to be your brief phone call, your triage, and they've actually added another visit for a little bit of a longer conversation. So there's the one that's 5 minutes, and then I think it's 11 to 21 minutes is the second one now. So those two are available and will continue to be available.
And Christie, those have to have had an in-person visit within 7 days of that virtual visit or that virtual check-in. Is that accurate?
Yes, you can't. You cannot bill for this service. Obviously, you can do one of these, but you cannot bill if they've had a visit within 7 days, or the triage leads to an immediate in-person service with you. The e-visit, the online portal visit, this is something that is taking off. You'll talk with your EHR vendors. They probably have workflows for this, but it's really a visit of communicating with your provider, not with voice, but online through a pre-populated template questionnaire, and providing medical advice back to the patient. That's called an e-visit. So again, there's some guidelines around it. You want to make sure you look at that. It's very clear in the CPT book, but that will continue to be available. The e-consult, this is taking off all over the place, both ambulatory and on the inpatient world. It's that provider to provider consult. So it's really expanding specialist access. And so when a provider asks another provider to review a record specific to a patient, not for general knowledge, but specific to a patient and the care of the patient at that time, that's actually considered now this e-consult. So please look into that. It really is helping to expand specialty access across the nation. And then RPM or RTM now that was just added. So we've got a lot of remote physiological monitoring and therapeutic monitoring that have billable codes around them, along with some guidelines. So again, these services are not going away. They were pre-pandemic approved. They will continue to evolve and will continue past the pandemic.
Yep, good point. Anything to add to that, Cynthia?
Just to, again, because of the consent form, there are times that you have to, for the e-consult, for the interprofessional consult, that you have to have a separate permission from the patient for one doctor to talk to another doctor. So, just have, make sure that you understand what all is involved before you go down that road.
Yep, keep that in mind for sure. Well, I can't believe we think we did that in just over 15 minutes, maybe just 20 minutes. So we only had 15 minutes. Sorry, we were right at 20, but this is our first one. So we weren't exactly sure how this is going to go, but it's our way to address the challenges that we're all having around Zoom fatigue and trying to get information out in short little bits and bites. If you do have any other questions, you can post them to our info@bluecirrus.com email address. Follow us on LinkedIn, Twitter, and Facebook, and then we'll make sure any of those questions get back to Cynthia and Christie. I'll make sure to answer those for you in a timely manner. Thanks so much for being here. Christie and Cynthia, thanks so much for doing this lightning session and being our first guinea pigs. Thank you.
Thanks for having us.
Thanks. Bye.